and Amanda asks, can you provide a deeper explanation of data completeness? It's still a little confusing.
As I look at the reasons for confusion, I see that it seems like a simple concept, but it has some subtleties that make it particularly confusing. I'll try to get around that with this explanation. Let's start with a definition. Data completeness is represented in quality reports as the reporting rate. So you can see that reporting rate and data completeness are synonyms. Generally, when you're reporting quality to Medicare, you're reporting a, a, a performance met rate, a performance not met rate, an exclusion rate, and a reporting rate. So it's deficits in that reporting rate that can harm you under the data completeness rules. 100% reporting rate is data that is 100% complete. A 50% reporting rate means you're reporting data on only 50% of your eligible instances, and it does not meet the 70% the data completeness requirement. Now, Medicare expects that you can't always have access to all your data. So they give you a little wiggle room. I think when these reporting systems were set up, the most common reason for lack of access to data was that not everyone had been moved to from a paper chart to an EHR. Now that's still true, but more people are in EHR now than when things got started. The other thing they recognize is that your best data does not always come from the legal medical record. Sometimes it makes more sense to go after it from a derived or a parallel process, like a tumor registry or a diabetes registry or a surgical log or a vaccination log or one of those many external lists that we maintain. And Medicare assumes that if it's not the legal record that it's coming from, there may be holes in the data. So there's different ways you as a registry, if you're serving as your own registry, or your vendor should be dealing with this, depending on that source of data. Medicare has told us if your data is coming from the legal medical record, your assumption is missing data indicates performance not met. Now, there's some variation in that with inverse measures, but let's ignore inverse measures for a moment and just say, in general, the lack of data means performance not met. The for instance is, think about flu shots. I should know from my billing data, and everybody has billing data because everyone generates bills for their work. You should understand from your billing data which of your patients is eligible for a flu shot. And to understand your reporting rate, you have to know what your denominator is. You have to know how many patients, which patients are eligible for that flu shot. Then when you look for the data, and we generally look in the clinical data for flu shot records, we find those that have had flu shots. So if you're looking in that legal record and you find a flu shot, that's performance met. And we're going to ignore exclusions for the moment and exceptions. So let's just think of met and not met. And if you don't find evidence for a flu shot, your best data is telling you that patient does not have a flu shot, so you can list those as performance not met. Now, if you're looking at a derived data set, Medicare says you can't really count on the entry being there. So a lack of data means a lack of reporting. Instead of a deficit on the performance, you deficit on the reporting. Now, that can be good for you by giving you a higher performance rate at the expense of your reporting rate. But if your reporting rate ends up getting below 70%, then it's not a valid report. Let's give you 3 examples to illustrate this. Let's say you check your billing data and find that 100 of the patients you saw last year were eligible for a flu shot. Now, first option is to manually or electronically search your legal medical record for the flu shot. Generate a report looking for a yes or a recorded date if they got the flu shot elsewhere. So you find 50 patients with a recorded flu shot, and those 50 are performance met. 50 patients have no flu shot recorded. So to the best of recorded knowledge, those patients did not have a flu shot. Because the numerators came from the legal medical record, the reporting rate is considered. Medicare assumes a reporting rate at 100% if you're doing a search of the legal medical record. So the missing data represents performance not met. Got a 100% reporting rate and a 50% performance rate. Now, let's think about a different practice with that same 100 patients eligible for flu shots. In this different practice, I'm keeping an immunization log that I judge to be the best source of data. So it's not in the legal medical record; it's parallel to that. It's in my nurse's station, and whoever's giving the shot, I expect to record in that log what immunizations are given. So my staff records that they gave a flu shot to 50% of my patients. But since this is not the legal record, I can't assume that everyone who's received a shot was given. Maybe there's a day we were busy and short-staffed, and they neglected to complete the immunization log. Also, there's the dynamic that if I've asked if they've had a flu shot and they say yes, we're not recording that in the log. It's recorded in the medical record, and I'm not retrieving the data for the report. So in this case, the missing data is considered a lack of reporting, but not necessarily performance not met. So my performance rate for the 50 I see, the 50 that are in the record, the performance rate is 100%, but the reporting rate is only 50% and fails the 70% data completeness requirement. For the final example, let's consider an ACO in an evolving community health system. There are 10 practices that are banded together in this case, each with a different medical record. Data is accessible for 6 practices, but inaccessible in 4, either because it's paper and they're not able to abstract the charts, or there's technical reasons, a lack of people with skill, or a vendor a contract that prohibits access to the core data. So each of our 10 practices have 10 patients eligible for flu shots. In the 6 practices with accessible data, I find 5 flu shots in each, giving us a 50% performance rate. And in those 6 practices, 100% reporting rate. But 4 practices can't supply data, and we don't know the flu shot status on the 40 eligible patients. With 60 patients in the accessible reported group, 40 with data inaccessible, we end up having a 50% flu shot performance rate. But we failed data completeness because we were only reporting on 60% of the patients. The 40 patients that were in the practices with inaccessible data drop our reporting rate. So, final note on data completeness: really, you can spend your 30% data completeness allowance on anything, whether it's because data is in paper charts and hard to get, or it's EHRs that you don't have access to, you don't have the technical skills to run the queries, whatever. Medicare doesn't care. What they do care about is gaming the system or cherry picking. They don't want you to drop the 30% of patients with performance not met, so you elevate your performance rate. Anything that is unbiased that you're dropping for other reasons of accessibility is fine, but they'll get upset, and if they have the freedom to push back at that or disallow the measurement, they will take that.